Okay, there you go.
Good to go. Yeah. All right, hey, everybody. I'm Chris. I'm one of the research residents. We're going to talk about some stomach stuff today. And then we'll have a talk on esophagus. We have 45 minutes for each of these, and there's a lot of material. So we're going to hustle like we just had Taco Bell on an Arizona road trip, and there's no gas station for miles. So we're going to go. And then shout out for Bluey. All right. So low hanging fruit, anatomy of the stomach. Did anyone list the four? Starting at the top left and working clockwise. Cardia, nice. And then the yellow portion. Keep going. Going to roll. Yeah, green. Body. Yep. Yep. Bingo. Pylorus antiprecipic. All right. Layers of the stomach. This is also important and relatively high yield. Okay, you want to go for it? Yep. Yeah. Yep. Yep. Awesome. All right. Lastly, blood supply. The four kind of or five like named vessels that go to the stomach. Anyone? Yep. Yep. Short gastrics. Yeah, the ovals are short gastrics. This cartoon didn't have it labeled, but I left it circled. Short gastrics. So that's good to know. They'll ask that sometimes. Okay, this is also annoyingly, this comes up sometimes as well. The cells and their functions. This is one by one. So goblet cells, what do they produce? A medical student. Okay, go for it. Mucus, nice. Parietal cells, what do they make? Intrinsic, they do make, what else? Kind of main thing that they produce. Acid, yeah. My hearing's bad, dude. Gotta speak up, please. All right, chief cells. What do they make? No, not gastrin. They make pepsinogen, which breaks down protein. So think of like a Native American chief, like super buff protein. And then D cells. A Native American, like a chief, buff, protein. Don't cancel me, sorry. All right. All right, D cells, they make somatostatin. That's like the brakes of the GI tract. And then G cells, gastrin, nice. Okay, cool. And there are certain areas of the stomach that have a more predominance of certain cells. Most notably, and will come up most frequently on the ABSITE, is the antrum has most of the G cells. All right, we're gonna move into hiatal hernias. There are types of hiatal hernias. You wanna take a stab, Daniel? What are the four types of hiatal hernias? Yeah. Yeah. God, you're so smart. Awesome. Yeah, I think that's all I want to talk about with that. GERD. So most the patient will have like those typical reflux symptoms, but in the question stem, if they have alarm symptoms, which are weight loss, dysphagia, yeah, GI bleeding, and anemia, yeah, those are going to push you towards like early endoscopy, more aggressive workup, concern for malignancy. Medical management with antacids, lifestyle modifications, so avoiding Taco Bell sucks, but gotta do it. And then indications for surgery. Joe. Obstructive. Obstructive from that's okay. Okay.
If you have like extra abdominal symptoms.
Yeah. Maybe right. Yeah.
High grade Barrett's esophagus.
Yeah, okay, so we'll talk about that. But basically, like, failure medical management, or you don't want to be on PPI forever. And then extraesophageal manifestations like hoarseness, cough, that kind of thing. Pre-op workup, this will also come up sometimes. Intern question. Manometry, yeah. EGD. pH, yep. And then last one, so imaging study. Upper GI, yeah, okay. And then pH testing, what's the score? What is it called? 14.72. Demeester. Gangster. Good job, guys. All right. Anti-reflux operations. So there's four types that are commonly tested. The Nissen is a 360 wrap. I remember that by like a Nissan 370, Nissan 360, like kind of close. Carson would appreciate that, but he's not here. Toupee, I didn't have a picture of my head, so this is one from someone else, but a toupee is the 270 posterior, goes on the back like you wear a toupee. A door is an anterior 180 wrap, so shut the front door. And then a Roux-en-Y gastric bypass is also technically an anti-reflux procedure. I didn't have any clever pictures for that one though. But these two have Nissen and Toupee have equivalent anti-reflux like efficacy. But I see toupees are done more often here at BAMC. By less incidence of like dysphagia afterwards.
I think now that there's that guidance, it's very possible that's gonna come up on the website.
Right.
It may be that it's one of those tough questions, so to ask kind of directly, but if you're asked to perform a anti-reflux operation and it's missing first one of those other wraps, I would err towards one of the other wraps.
Cool. Thanks. Okay, so some complications of anti-reflux surgery. The first one to talk about is capnothorax. So if a capnothorax starts to occur during the operation, so patient will have increasing CO2, be somewhat difficult to ventilate. What are some maneuvers that we do in the OR to address that? Largest tear, yeah. Yeah, basically open the tear, equalize pressure. You do the red rubber into the pleural tear and then out through abdominal wall to equalize pressure. But yeah, you want to do something to equalize that pressure in the OR. What about if, in PACU, you get the chest x-ray and then the radiologist calls pneumo and the nurse is freaking out? What do we do? Support, yeah, basically. Yeah, just oxygen, wait, like they'll be fine. It'll reabsorb. We had Dr. Rowland will talk about that quite a bit. Dysphagia is also a really common complication after an anti-reflux operation. So if they can't tolerate the secretions, I see this come up sometimes as an easy answer. What do we do? Redo. Yeah, back to the OR. If they have mild dysphagia, they're tolerating PO. It's uncomfortable. What do we tell them? Yeah, 4 to 6 weeks. It'll get better. It's due to edema. Like I got asked a question about that. That's what's the mechanism for this mild dysphagia? It's due to edema. But if they're still having dysphagia after those 6 weeks, then you want to think about potential complications like a stricture or failed repair. So you get an upper GI after 6 weeks. So really on the question stem, if they're asking about complications, you look at the timing of how far they're out from their index operation, and that'll determine kind of your next steps. Okay, peptic ulcers. This is fun. What's the #1 risk factor for ulcers? H. pylori. Nice. What are some other risk factors for peptic ulcers? NSAIDs. Yeah. What? Yeah. Gastrinoma. Okay, that's true. I didn't put that on there, but yeah, gastrinoma is a risk factor. Yeah, and yeah, H. pylori is the #1. NSAIDs are #2, and then the vices, smoking and alcohol, also is a risk factor. Treatment for H. pylori, this will come up. So there's 2 regimens. There's triple therapy and quadruple therapy. They will ask about this sometimes. Does anyone remember what triple therapy is? Say it again. Yeah, CAP. CAP. All right, and then shoot. Okay, quadruple therapy is a little bit different, but still PPI. And then you have bismuth, flagyl, and then tetracycline. Does anyone have a clever acronym for that one? No. Okay. 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 All right. Types of ulcers. This is also one of those annoying things that they will ask about, like what type it is. But where's the type 1? Yeah, distal lesser curve. About type 2. Yeah, 2 locations. Yeah, duo and then lesser curve. And then there's type 3, pre-pyloric. Yep. And then type 4, yeah, cardia. And then there's type 5 is anywhere from NSAIDs. Okay, cool. And this is just a graphic illustration of that. Which ones are related to high acid output? Why am I doing this? Y'all know all this. Okay, eponymous ulcers. These are fun. Cushing's ulcers. Who gets these? TBI. Yeah, TBI patients, curling ulcers, burns, yeah, curling iron. I've heard that hurts. I don't have enough hair to curl, but Cameron's ulcers. What are these? Okay, from caused by what? The diaphragm. Yeah, yes, yeah, pressure along the GEJ from the diaphragm. And marginal ulcers. This one's not eponymous, but yeah. At the GJ of Rouen-Wise. Oh, sad. Okay, yeah, thanks. Okay, halfway done. All right, we're talking about the vagus nerve and high acid production. All right. So the course of the vagus nerve, they will ask about this sometimes as well. Does anyone who knows what the course of the vagus nerve is? Like, yeah, LARP. People who play airsoft, LARPing. So yeah, so the left vagus nerve will then wrap anteriorly along the GEJ, and then the right will turn posteriorly. And then where they go will also come up sometimes. So the anterior branch goes to the liver and the pylorus and deliver fibers there. The posterior branch goes to celiac plexus and is also shorter. I saw that come up one time in a question. So the posterior just goes to celiac and kind of dissipates, while the anterior is longer. Oh shoot. Okay, I guess that's all I had on that. Yeah, so the vagus nerve is responsible for innervating the stomach and can be responsible for that high acid output. So talking about surgical treatment of the high acid states. So vagotomies are one of the more commonly tested acid reducing surgeries. So there's different levels that you can do a vagotomy at. There's truncal, which is higher up at the GEJ right here. So this will take out all the vagus innervation to the stomach. And then as you move, like more towards the terminal ends of the nerve, that becomes more selective. So this picture on the right is a I believe that's a highly selective vagotomy because they're leaving these fibers to the pylorus intact. So if a truncal vagotomy is done and all of this is knocked out, we need a drainage procedure. Otherwise, the stomach's just going to sit there and not empty. So the patient will need either pyloroplasty or an entrectomy and a Billroth reconstruction to allow drainage for their stomach. I don't think that they'll ask I don't think they'll put both and make you choose one. I think that they just want you to recognize if a truncal vagotomy is done, the patient will need a drainage procedure. But if the patient is getting a highly selective vagotomy, you don't need a drainage procedure because there's still innervation to the pylorus, but these have a higher recurrence rate of the ulcers. Okay, GIST, Dr. GIST. This will come up a lot. This is a talk all in itself. But some of the descriptions of this lesion, they'll say that it looks like a smooth mass under the mucosa on EGD, and then they'll ask what gene is associated with it. So this is a c-KIT mutation or a PDGF RA mutation. Those are two genes that they'll test on. Also, they might ask about bad prognostic factors that they find on the biopsy. So, or the size of the lesion, if it's greater than 10 centimeters, that's bad. Or if there's greater than 10 mitoses per high power field, if there's local invasion or met. So if you're reading the question statement, it's like, ooh, that sounds bad. It probably is bad. So if there any of these bad prognostic factors are present, the patient will get neoadjuvant therapy with imatinib before they go to surgery. But if it's like a small, low-risk lesion, you can take that patient right to surgery. I think they'll ask sometimes about the resection margin for a GIST, which is just 1 centimeter. And because these lesions spread hematogenously, you don't need a lymphadenectomy. So I think I got one question on that about what type of surgery do you do for a GIST. And then adjuvant therapy, these patients could be on imatinib or sunitinib. So imatinib is Gleevec, that's the first line, and then sunitinib is the kind of second line. Or if there are certain mutations, I don't remember which mutations, but sometimes we use sunitinib first line, but I don't think that would be tested.
So it's and then like sphincter preservation or G junction preservation using a method as opposed to going directly. into the
Okay, kind of like
Those are the.
shrink it. Okay, yeah. Cool. Thanks. Like, what was the mechanism of action of the drug? Okay,
Yeah, you need to be able to recognize if they call out the biopsy, that would be that for the test and mechanism of action for feedback or method.
cool. Thanks. All right, so we're talking about gastric cancer. There's two types. What are the two types? What's the one on the left? Intestinal. Yeah. The one on the right? Diffuse. Bad. Okay. So yeah, intestinal type. So on biopsy, they'll describe glandular structures for an intestinal type, and these have hematogenous spread versus diffuse. They'll describe that as like a poorly differentiated. Signet ring cells are like a high yield buzzword that will come up on a biopsy for this lesion, and these spread lymphatically. So going to a little bit more about diffuse gastric cancer, there's a hereditary diffuse gastric cancer. They like to ask about what gene is associated with that. CDH1, yeah. CDH1, which is an ECAD, it encodes for an E-cadherin protein. And then they'll also ask sometimes at what age you'll do a prophylactic gastrectomy for these folks on. Yeah, it's young. I saw 20 on up to date, but yeah, I think the BTK book says 18, but I went with the NCCN guidelines, which said 20 to 40 is that age window. But yeah, definitely err towards younger. Yeah.
The other thing we like to focus on is what's the other malignancy associated with this bacteria. Yeah. Lobular cancer.
All right. Yeah. All right. Lastly, TNM staging for gastric cancer. It's a pain in the butt to know, but they do ask about it. So differentiating T1A, T1B, lamina propria is a T1A, invading the submucosa is T1B, fits into the muscularis propria, that's a T2. T3 is subserosal, whereas T4 goes through the serosa. And then number of lymph nodes will also determine your end stage. So 1 to 2, 3 to 6, and 7 or more. So this is one of those things that you have to commit to memory for the test. And then Seward-Stein classification. Why is this important? Mhm. Yeah, yeah. So I think the question that they'll ask is they'll give you a description. They'll want you to know the numbers like 5, 1, 2, and 5, and then they'll describe where the epicenter of the lesion is and what type of surgery this patient would need. So they'll probably give you a lesion that's in the realm of a type 3, and then they'll want you to recognize that patient would be treated with a gastrectomy, not like an esophagectomy or anything like that. Type 2 is controversial. No one knows what to do with type 2. And then type 1 is an esophagectomy. Okay, gastric cancer workup. What are some things that these patients will get? I asked that poorly. Yeah, so they're getting an EGD with a biopsy. That's how we get tissue diagnosis, and then they'll also get an EUS to assess for lymph nodes. Yeah, CT chest, and then PET scan as well, and then labs, check their albumin, prealbumin, all that stuff. And then staging laparoscopy. I don't know if they'll ask about this, but usually, at least the NCCN guidelines say staging lap if it's T2 or T3. If you're undergoing a potentially curative resection, you need to make sure you need to look inside the belly and make sure there's no occult mets or anything like that. But if they have mets on CT, or if you're just doing a palliative surgery, you don't need to do this because you don't have curative intent with your intervention. Okay. Another thing they might ask about they'll want you to recognize who will be a candidate for neoadjuvant chemotherapy. And that's patient with any T2 or any nodal disease. These patients will get neoadjuvant. And then FLOT is the regimen we choose for them. So it's fluorouracil, leucovorin, oxaliplatin, and docetaxel. It'll be flawed. makes more sense, flawed. And then surgery for gastric cancer. So this is something they could also ask about as far as, or will ask about as far as who is a candidate for an endoscopic resection. So who could get an endoscopic resection? Like what's the characteristics of the lesion while this reboots? Yeah, small T1 well differentiated. So, and then what are the margins for gastrectomy? Just 5. Yeah, 5 centimeters. So yeah. Oh, okay.
I think that's actually, there was a recent ASCO publication in this, so we treating to receive kind of like gastric cancer.
Okay.
So there is an evolving body of guidance about that group.
Okay, cool. But
That's
unlikely
not-
to be tested. Yeah. But awesome. It's not 15? 16. Okay. Okay. All right, I'll update that. Thank you. And then if they could also ask like a patient that has like, obviously metastatic disease. And then they'll ask, they're obstructed and what's our palliative surgical treatment? So they could either get a stent past the obstructing lesion, or they get a gastroduodenal bypass if it's more distal lesion on the stomach. Okay, and then I don't think they'll ask about this just for, because this was also like me trying to visualize what a D1 versus D2 is. If they do ask, like you need at least, it's either D2 or modified D2, but you'll want to get it more than just the perigastric nodes if you're doing a like therapeutic lymphadenectomy during gastrectomy. Again, I think this is a little bit too minute for what they'd ask about, but this was more for my learning as well. Okay, so a few complications from gastrectomies that we'll talk about. Darn it. There's dumping syndrome, retained antrum, and then bowel reflux that we'll go over real quick. So dumping syndrome. So they'll describe this as patients had a gastrectomy, and then after they eat, they'll like get tachycardic, flushing, be dizzy, feel bad. And then sometimes based on the timing of their symptoms, they'll ask like, what's the mechanism of the patient's symptoms? So if it's an early dumping symptom, it's due to the osmolar load in the small bowel, because a bunch of fluid shifts into their intestines, and then that's what makes them feel bad. Versus if it's late, so a few hours after eating, there'll be an insulin surge, and the hypoglycemia is what caused their symptoms. And they manage these with just eating smaller meals more frequently throughout the day to reduce that, like, stimulus into the small bowel. But if they continue to have symptoms, even though they have small bowels, octreotide is the adjuvant treatment for that. Okay, retained antrum is when there are residual G cells in the duodenal stump, or potentially if you didn't get all the antrum during your initial resection, these cells will have alkaline fluid that they're exposed to from more proximally, and that causes them to release gastrin. And then it's this vicious cycle where the parietal cells then increase gastrin, and the parietal cells will then make more acid, and then they get recurrence of ulcers. If they ask you about a patient that is having recurrent ulcers after a partial gastrectomy, they will want you to check gastrin levels to make sure that you don't have you're not dealing with a gastrinoma, because the levels of gastrin will be different, and a gastrinoma is going to be much higher versus if they have a retained antrum. So I think it's like retained antrum will be like 300, 400, whereas a gastrinoma will be higher, close to 1,000. But you start this patient on antacids, and then if it doesn't get better, you may need to go back to the OR for like a re-resection to remove that antral tissue. And then bowel reflux is also something that they'll ask about every once in a while. So this is after patients had a Billroth reconstruction normally, and the reason that they have these symptoms is if they've had a B1, there's just a reflux of this bile that goes back up to their gastric pouch, or it's more common in a B2 because this is antegrade flow, which will then go into the stomach. And what they'll describe as a patient that is having symptoms, even though they're on an antacid, and then they might ask, what's the next test? And you'll want to get impedance studies, so it's pH testing, because it's going to show that it's non-acidic reflux in nature, so the pH is not going to be low. And then if they have a diagnosis of bile reflux, the treatment is with a conversion to a Roux-en-Y to prevent the bile reflux into their stomach. Okay. Follicular hyperplasia? Foveolar. Okay. Okay. Foveolar. Okay. Okay. Thanks. Okay. And then a few bariatric surgery things that come up frequently. So expected weight loss after various bariatric procedures. I've seen 2 or 3 questions on that. So after Roux-en-Y, you can expect to lose 70% of their excess body weight, whereas a sleeve gastrectomy, they'll get 50 to 60. And I did get one question about the BP diversion. That's the highest, but I don't think I've seen one of these patients in real life. And then also remission of diabetes after these various procedures. So Roux-en-Y has the highest incidence of cure of, fixing a patient's diabetes, where sleeve gastrectomy is about half. And then so this table is just good to refresh yourself, because it will give you various percentages and they'll want you to choose the correct one. And then also they'll ask about Roux-en-Y and the other comorbidities that it could treat. So more than half of most of these patients will have resolution of their metabolic disease, which is pretty awesome. But hypertension 40 to 80, hyperlipidemia 50 to 70. There are some things that the bypass does not treat, such as heart disease. Like if they have it, they have it. Like it's not, the bypass is not going to fix it. And then there's conflicting data on whether their sleep apnea gets better. But on the question, sleep apnea is not the right answer. Okay, hanging in there. Almost done. So slip gastric band, this will likely be an imaging question that they'll ask about. So a normal gastric band, there's something called a phi angle. So if you draw a line down the vertebra and then another line through the long axis of the gastric band, this angle that line creates is called the phi angle. Should be less than like 42, 43 degrees or something like that. Whereas in the question stem, they're going to give you a patient who's had a gastric band and then they're having like a nausea, abdominal pain after eating, and then they'll give you this KUB, and this phi angle is greater than that, 42, 43, because you can see this long axis is going down. So the answer on this for a patient that has this is you go to the OR and remove the band or revise the band or something like that. But in real life, it's just remove it. But yeah, this is a high yield imaging question. Okay, we have a few practice questions to go through. So Michaela, can you read this one? And then we'll do like popcorn. So after this, you choose the next person, the next question. Yeah.
Chronic dyspepsia, who's found to have a small lesion in the lesser third of the stomach and biopsy revealed adenocarcinoma. Endoscopic mucosal resection is most appropriate in patients with not any of the ones with. Okay, the C, 1 centimeter well differentiated.
Yeet. Get those points. Yeah, so it's a small, well differentiated T1 lesion. Okay. Ooh. Oh, brutal.
A 52-year-old man presents as gastric pain not relieved by twice-daily PPI, in addition to post-prandial antibiotics. He's negative for thyroid and has an issue of distal gastrectomy and filler off 2 resection, reconstruction for gastric admin. EGD reveals non-specific gastritis, and pH testing reveals multiple non-acidic reflux episodes. Which of the following is the most effective management for these symptoms?
Bam. Awesome. Yep. Does everyone understand why that is? Because it was in the slides, right? Yeah. So this patient has Billroth 2 reconstruction. So the antegrade flow of bile is going right past his remnant stomach, which is causing his symptoms. So conversion to a Roux-en-Y gastric bypass will then treat his symptoms.
Popcorn baby.
Bam.
Artificial gas protection for, just because of the stuff that you take for all.
Andrew.
Robert. Okay, traditional male long-standing history of smoking, increased the aspirin, chronic pain. Casual goal services for 4 weeks after completing H4 eradication therapy, further eradication. Don't remember result for 8 weeks, so he continues to have mild abdominal pain from PDG. PDG is performed showing a non-healed 2-centimeter ulcer along the greater curvature of the stomach. What is the next best step in therapy?
Non-healing ulcer. What are we gonna do? D. Yeah. Check it out. What's going on? Why is it not responding? So evaluating for if this is, it's sus. It's sus, but yeah. Sus. Thanks. All right, cool. 2 more questions.
Oh my gosh. Daniel.
It's supposed to be true.
Yes. No, wait, that's not it. Yeah.
E, yep, that's right. It's the left anterior, right posterior, and the posterior fizzles out at the celiac area. So does not reach the duo. I got this question wrong, so I put it in here. All right, last one. Pick somebody.
Look ahead of you. Popcorn baby.
A 55-year-old woman without a significant past medical history evaluated for anemia, weight loss, undergoes CT scan, EGD as part of evaluation. 10 centimeters smooth mass in the semi-occlusive pyloric region, endoscopic ultrasound and biopsy confirmed. GIST and CT mutation is positive, mitotic index is 1150, staging is negative for passages. So it's a high risk since it's 1150 centimeters, so you want neoadjuvant.
Yeah, nice, awesome, good job, team. That was it. That's all I had. This one, yes. Yeah. Okay. Ooh.
I'm sorry. We're talking very quietly.
Sorry.
It's
We appreciate your differences. Since it's greater than 5 centimeters and greater than 10/50 high power, or like 5/50 high power field, it's considered high risk, so you want neoadjuvant.
Also the location.
Size, if it's in a that key abutting the duodenum, I think is
In the pyloric
difference
region.
there. 'Cause if you shrink that and you can do a wedge resection of the stomach, that's great. Right now, if you're having to do a potential duodenal resection, that's a bigger operation. So I think when you're looking at neoadjuvant and admin, and this is still like an evolving area of research, I think I would look at location when choosing neoadjuvant as opposed to a higher grade of lesion. You're still right, but
Yeah.
I would just reframe that a little bit.
Okay. Okay.
Yeah, I think it's 13 and 16.
I feel like, I don't know why that's not easy.
Yeah, I would, for whatever reason, GIST is, there's a lot of like itty bitty like basic science things with it. That's on my list of things I usually review a couple days before the exam. 13, 14, and 15.
Okay, so if a patient has those two mutations, that's when you go with sunitinib instead of imatinib. Okay. Awesome. Cool. All right, any questions?
before we do the next one, and, I was gonna say, Glenn actually has a really great, YouTube lecture on it, that's on the, County Drive. And it's also on our channel, and I
That was
think
great.
that,
Thank you.
Putting that on double speed and watching it through